Hello everyone, my name is Jen Nolan and on behalf of Musculoskeletal Australia, I'd like to warmly welcome you to our webinar this evening on the topic of diet, nutrition and older people. I'd like to begin, however, by acknowledging the traditional custodians of the land from which we are broadcasting this evening, the Boonwurrung people of the Kulin Nation, and pay my respects to their elders, past, present and emerging. On behalf of Musculoskeletal Australia, I'm very happy to provide you with a list of our free consumer webinars for 2021. We have a great and diverse list of topics. If you haven't already registered for the whole webinar series, you can do so on our website, or you can also register for individual webinars that take your interest. When you visit our website, you'll find an extensive range of information, films and videos, apart from our other initiatives and services, such as our peer support groups, our MSK Kids program, our MSK newsletter, and our national MSK helpline. If you haven't already seen it, I urge you to also read the report of our National Musculoskeletal Consumer Survey, which we undertook last year. The survey report is titled Making the Invisible Visible and details the physical, emotional, financial and social impact of musculoskeletal conditions on people living with these conditions. It certainly makes for powerful reading. Our presenter for this evening is Professor Judi Porter. Judi is the discipline lead for dietetics at Deakin University. Her background is as a clinical dietitian, health service manager and academic. She has worked in various roles in Australia and in the UK, developing expertise in malnutrition and ageing. Judi has a particular interest in the nutrient requirements of older adults aged 80 years and over. Without further ado, I'll hand proceedings over to Judi. Thanks very much, Judi.
Jen, thanks so much, and thanks to everyone at MSK for inviting me along to present tonight. I'm really pleased to present on behalf of our team at IPAN. And following up from some comments there from Jen, it really is difficult for me to provide dietary advice specialised for every one of you tonight because, pleasingly, everyone is different. And I read the report provided by MSK with a lot of interest in preparing this webinar tonight to learn that there's around 7 million Australians that live with a musculoskeletal condition. And that's more than the prevalence data that we have for all other conditions in this country, including some of the most well-known: obesity, cardiovascular disease and cancer. And of all of these conditions, they're shown there on the right. There's so many of them. Musculoskeletal conditions are often combined with other physical problems. And so while I've done my best to create a webinar for you all tonight, it's evidence-based, but it's also general. And so I'd like to say that this webinar tonight does not replace any advice that any of you have received from medical or allied health practitioners that will have tailored their advice just for you. Okay, so of this report, I learned that there were many respondents who reported that they've consulted at various times with medical specialists regarding nutrition problems, including 5%, just 5% of the respondents reporting having seen a dietitian. I also realised that the cost of visiting specialists and allied health appointments is one factor that contributes to financial stress for all of you. So I'm really hoping that you find tonight's presentation really quite practical, so that you can have some strategies to take away into your practice. So I'd like to talk about first, I guess, nutrition across the lifespan, and how we all start so little and so sweet. And look, we turn out to be old and older and still so very sweet, but having traversed many life stages and stories, adventures and experiences across this life. And I'd also like to acknowledge that nutrition across the lifespan changes. as does our physical capability, our financial capability, and all of those family life stages in between. So what I'd like you to do is reflect, I guess, that as you move from a baby into a toddler and then into a child, into an adolescent and to an adult, your nutrition requirements all changed. Some of you now may be in middle age, perhaps. In those years, the 40s, 50s, 60s, which we're really focused on reducing the risk of developing chronic diseases. So things like I alluded to earlier, cardiovascular disease, cancer, try not to put on too much weight. And there's some very well-known dietary guidelines in Australia to support nutrition in these age groups. They're focused, they're called the Australian Dietary Guidelines, and as shown on this slide, the Australian Guide to Healthy Eating, which is a plate essentially broken into 5 sections. You can see there's breads and cereals, vegetables, fruits, dairy products, encouraging at this stage of life typically lower fat dairy products, and meat, fish, chicken and protein alternatives being those core food groups that we all should be eating every day. Around the outside though, you'll see that there's some other items, things to use in small amounts, fats and oils for example, but also down the bottom right, lots of those what we call treat foods or discretionary items that we really should be keeping those to a fairly low and infrequent food intake through those middle life years. And water, of course, is the preferred drink, but in order to reach, for most of us, 6 to 8 cups of fluid a day, tea, coffee and other low energy foods also play an important role in getting us our fluid requirements. So I'm sure many of you will have seen this before, but for many older adults, this is where their nutrition guidelines stop. And so what I'm trying to get out of tonight's session is to show you that actually there is a next phase to nutrition requirements as we age. In this middle life stage, I really encourage you to select foods from across the food groups. So we're looking to select foods every day from all of those 5 sections of that plate, but making sure also that you're choosing different colours of food. So choosing from a rainbow of vegetables and fruits, for example, because these all provide different nutrients and other sort of micronutrients which our body needs. So not just, for example, choosing green vegetables only, but trying to choose across a rainbow. And I also am aware that budget is really important. We're all on budgets of different shapes and sizes, but to acknowledge that fresh, frozen and tinned foods are all equally good for you. Okay, so if you can't get out to a supermarket regularly, then tinned fruit and veggies, frozen vegetables are a great substitute and often more cost effective than looking to get fresh foods all the time. Looking again in these middle life years to try and minimise adding oils, salt, etc. to your foods, but using things like herbs and spices to add flavour. And really, as I mentioned earlier, to try and limit those discretionary, those typically ultra-processed foods that are high in fat and high in sugar, to avoid putting on extra weight and contributing to those other risks of chronic disease that I talked about earlier. However, at some point, okay, as I talked about earlier, transitioning from being a child into an adult, our nutrition needs also change as we move from middle-aged into older adults. And this transition is really lost in the public presentation of what adults should eat. And we, as dietitians, are encouraging the Australian government in their current review of the Australian Dietary Guidelines to develop guidelines for older adults, because the current guidelines do not match the needs of this population into their 70s, 80s, 90s, and of course the centenarians. So we really need to focus in these years of trying to avoid unintentional weight loss. Rather than worrying about getting cardiovascular disease, we need to stop this unintentional weight loss. It leads to malnutrition. Many of our patients in hospital and residential aged care are malnourished. So what this malnutrition is, for those of you who aren't perhaps familiar with the term, people often think malnutrition just happens in famine times in Africa, but actually it's alive and well in Australia and other westernised countries. And it occurs when there's a deficiency in dietary intake, particularly when there's increased requirements, but also when we don't eat enough for our body's needs, or from a combination of these factors. Malnutrition is known to have a whole range of adverse effects, including increasing the risk of falls, of pressure injuries, and it also increases hospital admissions and readmissions. So to reduce the risk of becoming malnourished at this life stage, there needs to be less of a focus on following our current Australian dietary guidelines. Instead, a priority is to meet nutrition requirements. And for many older adults, this means that we should, instead of following that strict fruit and veggie arrangement that I talked about earlier, but consuming now more high protein, more high energy foods. And I'm going to go into those tonight. So a prompt for each of you to ask yourselves. Thinking about these questions for you, also though, your friends, your family. Have I lost weight recently without trying? And if yes, how much weight? And have I been eating poorly because of a decreased appetite? That's our classic standard nutrition screening process that's used in many Australian hospitals and care facilities. Some triggers are you at risk of malnutrition? But others are, do my clothes fit? Does my belt fit? Or have I been tightening up those holes on my belt? And really important, particularly for those very older adults, do my dentures fit? If your dentures don't fit, then you won't be able to eat well. You won't be able to chew well. You won't be able to eat your regular foods. You'll end up with pressure ulcers in your mouth, an ulcerated mouth. You'll end up not using your dentures and your whole nutritional status will decline. So really, I hope that they can be a list of triggers for you around your own and your friends and family's malnutrition risk. And this problem of malnutrition in older adults is really quite a wicked problem. Relating to this problem, we've conducted hundreds of studies in the nutrition field, hundreds of studies and clinical trials on this topic in the past 20 years or so, in all settings, for people living in the community, in hospital and aged care. There's been multiple sets of expert guidelines developed. But my take home from all of those trials is that there's actually no magic cure. But prevention is better than cure. And once you're in this vicious cycle of unintentional weight loss and malnutrition, then it's difficult to turn it back in the other direction. As I've said, malnutrition in older adults has negative outcomes. I've mentioned some, there's others. It's known to reduce quality of life, increasing readmissions to hospital, and also a higher mortality rate. Individuals who are malnourished are also at higher risk of falls and fractures. So it's really important that we get on top of this problem before it happens, or in those very early stages. So putting away those dietary guidelines that we've focused on for so many years. And I've heard so many sweet, lovely older adults in my clinical practice saying to me, I'll ask, so Mrs. Smith, how are you eating? Are you eating well? Oh yes, dear. Make sure I get my veggies every day. And I'm so pleased they're having their veggies, but I'm not pleased that they're filling up on vegetables, which are so low in energy, at the expense of the high energy, high protein foods that they actually need in order to avoid this unintentional weight loss. So examples of these foods are things like meat, chicken, fish and eggs, and other protein sources such as beans, lentils and tofu. Patients will also say to me, oh yes, I eat well, I choose low fat everything. I'm on my semi-skimmed or skimmed milk and I'm on reduced fat this, I love my cottage cheese. And I just shake my head and think, it's so perfect for those middle-aged years when you're trying to avoid chronic disease. But now you're in your 80s and 90s and I'm seeing you for your unintentional weight loss, and this is why you're losing weight. Instead, it's really important that for this group of people that they choose full fat options, okay? So turning back to thinking, you know, I'm not trying to lose weight, I'm trying to put weight on here. So choosing full fat milks, full fat cheese, snacking on cheese between meals, and having full fat yogurt. So not trying to get anything that's got diet or low fat on the label, but instead going for all of the full fat options. Also things like creamy based soups and sauces to really put on those extra calories and turn that weight loss in the opposite direction. Look, there's lots more foods to enjoy when you're malnourished and at risk. And look, I think this is a lot of people's dream really, for a dietitian to sit with them and to say you actually need to be having more of those custards, the milkshakes, milk-based hot drinks, more desserts, more ice cream, more chocolate. So you need just to flip your thinking so that you're not thinking about weight loss but weight gain. And how do I gain weight? It's through eating all of those foods that you've potentially been trying to avoid for the last 30 or 40 years. But this is how you need to really flip that dietary intake in these later years to avoid unintentional weight loss. Whilst eating these things though, let's face it, you can't eat all day. We don't have room for that much food. And certainly as we age, our appetite and capacity for eating food declines. So instead, what we're trying to take out of our diet is those low fat and low nutritional foods such as broths, thin soups, the salads, the veggies that don't have any butter on them. Out they go, in with high energy, high protein foods. And of course, I must say I would have heard at least 1,000 times in my years of practice that I split my meals on wheel meal into 2 meals, dear. I don't have any inclination to cook at night, so I spread it across the day, which is lovely in a sense that I appreciate you might be cooking for one, but one meal is meant to be one meal, not 2 meals. So you really do need to work up some strategies for that other meal, whether you're having your meals on wheels at lunch, then you need to be looking at some toast and some other, adding to that some high protein options with perhaps grated cheese on in the evening to make a quick, easy snack-like meal, but one that's still going to provide you with lots of nutrition. Okay, so moving from that community setting now into hospitals. And in hospitals, consistently internationally, prevalence of malnutrition are around 30 to 50%. And so the years since when I started practicing as a dietitian, when patients would stay in for 1 to 2 weeks, of course, are long gone, with patient turnaround time in our acute hospitals now much faster. So we only have the sickest and typically many of the oldest patients in hospital these days. They're the most at risk of malnutrition and most at need of these high energy, high protein meals, but their management is made more difficult in the hospital setting because patients are sick. They don't have a good appetite, they don't feel well, and there's a whole range of other priorities during their admission. And this is challenging to manage because in that hospital setting, nutrition, of course, is everyone's problem, but nobody's job essentially. And it would be wonderful if we had heaps and heaps of dietitians, but typically there's a lot of other priorities in our public health system. So we've done quite a bit of work looking at how to prevent and treat malnutrition in hospitals, including some studies that I've been involved in. And what we do know works is providing mealtime assistance to those patients who need support, providing oral nutrition support products for those patients who really can't meet their oral nutritional intake by meals alone, and using energy-dense meals. So looking for similar strategies as I've talked about earlier. Those smaller fortified meals, cooked breakfasts, and those high energy and high protein snacks. So what we found in the subacute setting, so that transition setting between acute and moving back into your community care residence, wherever that may be, home or into an aged care facility, but there's a level of friction on the wards in terms of actually providing the nutrition support that is needed in this setting. And it's absolutely no one's fault. Everyone who's working in our subacute facilities is doing their best, but they are under a lot of pressure, a lot of time constraints, and also these really competing priorities. It's a real tension that exists as to trying to meet the needs of all of the allied health medical staff, but also all of those roles that the nursing staff play around that direct patient care, providing medications, and of course providing patients with support that they need right across the 24-hour period. So it's challenging to meet mealtime needs in that setting particularly, and it's an important setting because people may stay in that setting for a couple of weeks as compared to a couple of days in the acute hospitals. But then transitioning into residential care, and WHO recognises that there's some particular challenges as we transition into residential care, with malnutrition a real risk factor into this setting as well. And it can be one of the reasons that accelerates people transitioning into residential aged care, because they're in this cycle of unintentional weight loss, of risk of falls, fractures, and then trying to manage in their own home environment. So malnutrition is rife in residential aged care, and again this spiral starts right back when people were typically in their own homes. Many patients in this setting are malnourished, and the prevalence ranges vary, of course, depending on how you assess it and different homes, but it can be a prevalence from around 22% right up to a staggering 50% of residents that are at risk of malnutrition or malnourished. And look, there are some really clear guidelines around how to support people from not becoming malnourished in this setting. What's really important is that we screen residents on admission into aged care settings and regularly thereafter to make sure that their weight and other nutritional indicators are not deteriorating. It's really important that we make every single mouthful count in this setting. And some recent research that I've been involved with found that only 9.8% of aged care residents who were consuming a regular or easy-chew diet actually completed their main meal. That's not many, less than 10% of every meal getting finished. And that's a big problem, and that's why we've got such a high prevalence of malnutrition. So in Resi Care, we're looking to fortify menu items, again through adding high energy, high protein fortification techniques, including skim milk powder, cheese, cream, etc., to boost that energy and protein content of meals. Also adding those high energy, high protein snacks and desserts, dairy-based snacks, hot and cold milk-based drinks, and those tasty desserts that really are very calorific and energy dense to stop weight loss. As you're getting, I'm sure, the picture, such a different set of nutritional needs as compared to the dietary recommendations for the general adult population. But look, there are some other nutritional priorities in aged care, and I've, in my role as subject matter lead for aged care for Dietitians Australia, have been doing a lot of work in responding to some of the reports coming out of the Royal Commission, of course, into aged care, and some of the other nutrition priorities that we've recommended as to make sure that we're providing mealtime assistance where needed. It's really important that food presentation is considered, that food service systems are used preferably where residents can choose at the point of service. They can point to the lunch or the dinner meal that they'd like, rather than needing to order in advance, thinking of cognitive impairment, but also people's food preferences change from day to day, and let's face it, the weather. So it's really important that people can make that choice at the point of service. As I mentioned earlier, oral health issues are really important to consider, that dentures are well fitting and that residents have their dentures so that they can really optimise their nutrition intake. But of course, some people have swallowing issues and will need texture modified diets and thickened drinks. Particularly important when we're trying to meet hydration needs of around 1.5 litres per day. We really have encouraged aged care staff to receive food and nutrition training and top-up training, and also that dietitians have a really important role to play in supporting menus and food service systems, also though providing that one-on-one resident care when it's needed. I don't normally practice in the area of diet and arthritis or anti-inflammatory diets, but the team at MSK have asked me to prepare a couple of slides, which I hope will be of use for those of you who have this condition. And so I've done a little bit of searching and have found that the research is fairly patchy in terms of rheumatoid arthritis, particularly because dietary patterns research is difficult to do and it's expensive. So except in those cultures such as in the Mediterranean, of course, people who follow the Mediterranean diet, it's difficult to implement a different dietary pattern well into other populations. It's expensive and difficult to ensure compliance. So looking at reviews of the highest quality published in a Cochrane review, conducted now about 10 years ago. They conducted a review, the group by Hagen and others, looking at the dietary interventions for rheumatoid arthritis, and I've included the link there. And they looked to improve the symptoms of people with rheumatoid arthritis and found that a wide variety of special diets have been followed, include limiting certain foods and increasing intake of other foods. And dietary approaches that were reviewed in this overarching type umbrella review include vegetarian or vegan diets, the Mediterranean diet, as I mentioned, but also elemental or elimination diets. And the review found that it was uncertain whether any of these diets actually improved rheumatoid arthritis outcomes, including those around pain and stiffness. And it acknowledged that diets may be difficult to follow, and of course, unintentional weight loss often results. And I've talked at length tonight in this presentation around the challenges of turning around unintentional weight loss. So that there was no very clear message coming out of the broader body of literature. But I'd also like to note that the anti-inflammatory diet has gotten a lot of attention in more recent years. And that is, of course, where foods and particular food components may reduce inflammation on patients' symptoms. And so these include difference of the fatty acids, probiotics, some of the vitamins, and antioxidants, things like fish, for example, salmon, many of the vegetables, whole grain cereals, vegetables, some of the fruits, etc., and nuts. So you probably have, if you're looking to implement an anti-inflammatory diet, you've probably done some reading in this space. And there's quite a bit on the internet I'm aware of. So I looked at a very recent trial published in one of the highest ranked nutrition journals, the American Journal of Clinical Nutrition. And it was a trial of just 50 participants. As I said, these trials are difficult to do very well and to publish well. So in this group, this small number of participants received either anti-inflammatory foods or a controlled diet, and they followed that diet. Then there was a 4-month washout period where they just followed their normal diet, and then they switched diets. And they were looking at a range of outcomes, but particularly focusing on this disease activity score, and as I mentioned, a range of secondary outcomes. But even in this trial, the best tightly controlled trial, the most recently published literature in this space, there were mixed findings depending on which statistical approach was taken. So the authors concluded that there were some potential positive effects of the anti-inflammatory diet on the disease activity, but that more research was needed. While other commentators, there was an editorial written on this study, have suggested that really it's very inconclusive, this space, and that there's really still quite a bit of work to be done. My concern, of course, is that some of those recommendations around anti-inflammatory diets are, of course, at odds with those dietary recommendations for those older adults that I've mentioned. And so this is why I've said from the outset, it's difficult to balance those individual needs for all of you. And so I would encourage you to seek some professional guidance if you need it. Right, well, just to tell you a little bit of what's happening at the Institute of Physical Activity and Nutrition at Deakin University, where I work. There's, of course, always heaps going on in this space. We've got a really active team of researchers at IPAM, and there's a range of studies that are being conducted, and these include looking at telehealth as a model of personalised healthcare service delivery, to optimise musculoskeletal health and mobility in older people. Also, another trial looking at exercise and nutritional approaches to prevent and manage muscle loss in people with non-alcoholic fatty liver disease. We've got some other projects there, one looking at an in-hospital mobility initiative, and a series of projects looking at digital health and how we can maintain musculoskeletal health and physical independence in older adults. Some of the studies that I've been involved in recent months and going forward over the next few months is exploring the energy requirements of older adults, both 65 years and over, and as when Jen introduced me at the start of the presentation, a particular interest in the population 80 years and over. There's been very limited amount of research done in this very older adult population, and still so much work to be done to understand nutrition needs in this population. And we're looking here at gold standard measures of doubly labelled water to understand energy requirements. Also, I've been involved in some work around looking at fortified diets for residents in aged care facilities, looking at the effects of motivational interviewing to increase walking on health and economic outcomes, and also, of course, to look at sustainability, both in hospital food services and in aged care food services, where, of course, we want people to be eating more, but we do not at the same time want to be putting more food into landfill at the expense of the environment. So that brings me to the end of the presentation tonight. I hope that was interesting to everyone out there. And Jen, I'd like to hand back to you to see if any of our listeners have any questions.
Thanks so much, Judy, for what was a really fascinating presentation. That was news to me, I have to say, with regards to, you know, the different dietary approaches to be taken with older adults. So I found that quite fascinating, I have to say. The other thing is, I think it's fabulous that you're actually looking particularly at that age group and doing research with that age group, because often older adults are missed out in research. They're often not the key focus of many research initiatives. So I think it's fabulous that you and your team at IPAN are doing a lot of work around older adults, and you know, even thinking about diet and the relevance of it to musculoskeletal conditions. As you sort of said, people who are malnourished are then at risk of falls and so on. So certainly, you know, there's strong links between the importance of nutrition and diet, and also good musculoskeletal health. So thanks for a very interesting presentation. There are several questions that have come through, so we'll work our way through those, starting from the very beginning. Someone mentioned, Judy, if there's any evidence that the keto diet is helpful in medical conditions of the age or in the aging process?
Look, that's a really great question, and hasn't the keto diet and research in this space really taken off in recent years? I will say, Jen, I haven't seen any research around the benefits of keto diet in older adults specifically, but certainly we can take some things away from the keto diet, in that actually we are encouraging people to be having more protein and more fat, and less foods perhaps that are not as nutrient dense. Things such as perhaps having less of those broths, those soups, those salads, those low joule vegetables. But as you saw from my slides, we're certainly not presenting carbs as the bad boys, so to speak. And I think that there's a real value in carbohydrates, particularly refined carbohydrates, dare I say, in terms of getting those calories in quite quickly and quite easily. And you know, we try so very hard for patients who are in hospital to be increasing their energy intake through a whole range of sort of pharmaceutical approaches with oral nutrition support products, etc., Jen. But actually, when it comes to it, a chocolate bar, a Tim Tam, an extra bowl of ice cream, I mean, they are really great ways to get your energy in quite an efficient way. So I think that there's some parts that you can take away from the keto type diets, but equally I think that carbs really have their role as well.
And Judy, you mentioned the Mediterranean diet, but someone asked the question about, are you sort of saying that it's necessary to minimise the use of such things as extra virgin olive oil, which a lot of people sort of tend to recommend is good to include in diets?
No, maybe that was taken a little bit lost in translation, Jen, so I can clarify that. Certainly olive oil, and whether it's extra virgin or not, I don't think that there's particularly any difference from a chemical perspective. I'm sure there'll be some nutrition scientists that would fight me over that one. But look, in terms of getting in lots of monounsaturated oils, certainly any of the olive oils are wonderful, of course. And that is very consistent with the Mediterranean dietary pattern. And so looking from that perspective of the anti-inflammatory diet and from those guidelines around healthy eating right through our middle stages of adulthood, certainly olive oil is good. It's also good as a fat product, an oil to be using for older adults. So whether you're using butter, fat, margarine, olive oil. For me, they're all good sources, really high energy sources to be having as you age into the older age category.
Yes.
I wanted to clarify there. Yes.
Yes, and an interesting question. You mentioned that point about eating the rainbow, different coloured versions of fruits or vegetables and so on. Someone raises the question: is it better to eat the rainbow or eat in season? Is that important? Eating more seasonal vegetables and fruits and so on, rather than just focusing on eating the rainbow?
Yeah, I take the point there, and certainly from an economic perspective, from a food miles perspective, actually a sustainability perspective, it's really important that we do eat in season. And let's face it, you know, we're about to come, you know, grapes are finishing up now. We're right into the citrus season, aren't we? Apples and citrus right through, and they're the typical foods that Australians would eat through the winter, and don't perhaps have that colour diversity. But I think we can complement that here and there, perhaps by the addition of berries into smoothies and that type of thing, frozen berries. But equally, you know, if you're not eating perhaps as many of the rainbow of fruits through the winter months, that you can focus on a good rainbow of vegetables. So trying to get away from those white veggies, those classic sort of stodgier white veggies, and making sure that you're also getting some greens, some yellows and orange vegetables, some capsicum, tomatoes, etc., so that you are eating where you can right across a different range of foods.
Mm-hmm. And Judi, another question: how do you balance this advice with regards to increasing your sort of, I suppose, carbohydrate intake and so on, the high protein, to avoid unintentional weight loss? How do you balance that with type 2 diabetes and with cardiovascular disease?
Correct, and this is why, I guess, Jen, I did say to you right up front and when we caught up last week how difficult this is to provide this sort of dietary advice, because everyone's got their own personal circumstances. And so that's when I would encourage you to be seeking some advice around how to balance that. And I guess at some point, the scales tip, don't they? Instead of being focused on really trying to minimise your risk of chronic disease, you know, you don't want to be in your 80s, in your 90s, and being so worried about your cardiovascular disease that you essentially fade away in front of our eyes. There's no benefit to that at all. And so that's why I'm encouraging people who have got these, I guess, multiple different factors to consider around their diet, that they would be able to seek some dietary advice. Of course, seeing their GP around their chronic disease plans, and maybe checking in with a dietitian that way, or perhaps through outpatients at your local health facility.
Mm-hmm. And Judi, good question. How do vitamins serve as a sort of nutritional support to older adults?
Look, that is a good question. One thing I'd like to acknowledge is one of the challenges that we have in hospitals and in some residential aged care facilities that rely on what we call a cook chill meal service. That is where food is perhaps produced off-site and then comes to the hospital facility already prepared but chilled, and then is reheated. That type of food preparation system is at risk of loss of the water-soluble vitamins, so vitamin B and vitamin C. And we have noticed, not only through long-term residents, but also some patients coming in from the community, that scurvy has arisen again in Australia, often, of course, associated with, you know, the boat trip out from England. In the olden days, it actually does exist in Australia right now, and I've certainly been involved in treating a couple of circumstances of scurvy. So some hospitals will recommend vitamin C for patients who are receiving food from a cook chill facility over a longer term. perhaps over a month period, reliant on cook chill to be fortifying for vitamin C. But for the rest of the vitamins, I mean, let's face it, the vitamin industry in this country is very rich. It's very powerful. You cannot walk into a supermarket or a pharmacy without being bartered with this perceived need for vitamins. But actually, if you're eating well, you don't need any of them. It's a bit of a money spinner. And so vitamin C, if you don't need it, go straight down the toilet, as an example of a vitamin that's so commonly taken. Equally though, Jen, we do know that older adults particularly are at risk of vitamin D deficiency. Okay, they're often institutionalised, they're indoors a lot. When they do go outdoors, they're nice and rugged up, nice and covered up, which means their skin can't be absorbing the sunlight and vitamin D. They're reliant more on vitamin D from food. So for people at risk of vitamin D deficiency, your doctor may recommend supplementing vitamin D. But look, again, it's a level of individualising the advice. For the majority of us, we don't need any additional vitamin or mineral supplements, but for the odd occasion, of course, that they can be needed.
And Judi, the impact, what would be the impact of better dental care on nutrition for older people?
Yeah, it's a real challenge. Let's face it. Teeth are really hard to look after, particularly if someone's come into, they're expensive to look after. They cost a lot to go to the dentist. So I understand that. People are reliant on someone often to get them to the dentist. They come into hospital and there's not a lot of dental support for patients in hospitals. And then, of course, they're transitioned typically into residential care facilities where it's, again, really difficult to treat a patient or resident's dental needs in hospital, in residential care. You actually can't get a dental chair easily into a residential care facility, and then all of those bits and pieces that dentists put in your mouth, all of those tools, all of the suction, all of the support. I mean, I'm not a dental specialist at all, but dental care is really complicated, but really important in terms of relationship with what you can eat. And so if people have got oral pain, they can't be eating well. They'll be transitioning off of that regular diet into more of the softer diets or the more puree type diets. And of course, they become more dilute, Jen. And instead of being, really energy dense, of course, to get them into that puree state, they've had to be diluted, sometimes with water, but ideally with cream and with other high energy nutritive products to dilute them. But still, it's not the same as eating, if you can, a regular meal.
And another good question here, Judi, like with different migrant groups and say particularly older people from an Asian background, would you suggest this same approach with regards to the high energy, high protein, high carbohydrate diet, that approach be incorporated into their sort of particular diets?
Absolutely. It's really important that we meet energy requirements. However, I'm wanting to encourage, I guess, that there may, of course, be cultural diversity to the guidelines that I've provided. I've provided, I guess, a classic westernised approach to fortifying meals and snacks. But this could be done in terms of, boosting the energy and the protein content, but still making a diet consistent with someone's cultural preferences and cultural beliefs.
Thanks for that. And there's been someone's written in saying that there's a high sort of correlation or strong evidence between weight loss and pain reduction in arthritis management. Is there anything you would add to this? I guess if people are experiencing a lot of pain, it may also affect their sort of the diet and their dietary intake?
Look, certainly, although, Jen, I guess I've said to you from the outset, I'm not an expert in arthritis at all, but what I can say is if you do lose weight, typically your mobility improves. And so while I've talked a lot about tonight about malnutrition and unintentional weight loss, I can acknowledge that some people do want to lose weight. It would be good for them, particularly around those middle years of adulthood. And let's face it, the more you carry around your tummy, around your hips, around your thighs, the more difficult it is to move. And if you think about, you know, a big bag of oranges weighing 3 kilograms, that's the classic bag of oranges that you'll pick up from the supermarket. That's 3 kilograms. If you were to pop that round your waist and try and do a few times up and down the stairs, you would find the effects of 3 kilograms additional weight. So equally, in losing some weight, even a small amount of weight, one's mobility does improve in that it makes it easier to get out of the chair. It makes it easier to go up and down the stairs, or to walk, you know, shorter distances. So yes, for those of you who actually would like to or could benefit from losing weight, yes, I think that you may have some benefits potentially to your mobility.
We seem to have lost you on camera there for the moment, Judi, but we're close to finishing soon. Anyway, we've got several more questions here. So as long as you can hear me, there we are. You've got your back again.
I'm back.
Good on you. So a question, would you consider water an integral part of a person's diet? If so, and how much? And can water be substituted with tea or coffee?
Yeah, look, that is a great question. It's one that's commonly asked, and I must say I'm a mad tea drinker myself, Jen. It comes from having 6 years working in the NHS. I do love my cups of tea, and I could have many more cups of tea than water, I confess. And look, tea is completely fine. There's also some health benefits to coffee, although I would say that coffee, you know, late nights perhaps not the best to help you get to sleep, but yes, they can be substituted for water, as can in the case of someone who's who's following the guidelines consistent with the Australian dietary guidelines, Jen, of using low energy drinks such as diet soft drinks and diet cordial. They also count as fluid, and so particularly in the really hot periods over summer, you know, there's nothing, you know, nicer than a really cold refreshing drink. But of course I'd be encouraging people to be having low joule drinks for those middle adult years rather than having sugar sweetened beverages.
And just with regards to the amount of fluid intake, what would you suggest should be a daily amount? Is that possible to say?
Yeah, that's right. Yes, 6 to 8 cups of fluid a day. So a cup typically is 250 mils. So we're looking to try and get to 1.5 to 2 litres. You can drink more than that, particularly if your job needs you to. If you're out in quite a manual job, then you'd need to be having more than that. If you're very physically active, if you're doing lots of sport, for example, you would need to be drinking more than that. But when you get over, you know, many litres, in the case of my time working with people with chronic mental health conditions, polydipsia is another condition where people drink far too much fluid in a day, that it can actually disrupt their electrolyte balance. We're talking there of 7, 8, 9 litres in a day. I wouldn't recommend those volumes. So stick to your 6 to 8 cups of fluid for most people, and that should see you through.
And also, just a question, is there an alternative for high protein foods if someone's not able to tolerate milk-based snacks or foods?
Yes, in that case, if we're trying to reduce the amount of dairy, and I'm thinking there perhaps in the case of people of an Asian background who don't have the same ability to digest lactose particularly as people of a Caucasian background, or if they don't like milky based drinks, then yes, instead focusing on the other group that's high in protein, which is meat and meat alternatives. So I mentioned fish, chicken, meat, tofu, beans, legumes, peanut paste, etc. They're also really high in protein, and so you could focus your high protein options into that group. So perhaps adding, in terms of making that applied and practical for your audience, Jen, having sliced cold meats on crackers rather than encouraging cheese and crackers, for example, to really try and boost your protein intake right across the day.
Yeah, and look, I must say, Judi, there's a couple of questions, and just to the people who have posed these questions, a couple of questions that are more specific to individual circumstances. So in fairness to Judi, I won't actually present those questions because, as Judi has said a couple of times, it might be best to sort of seek advice from a dietitian directly who can actually sort of hear the full story and circumstances rather than putting it as a question to Judi this evening. There's one last question before we finish up, though, of a general nature. Can a good diet improve one's sleep pattern, which I think is very important?
Oh, it is. Oh, look, gee, sleep's not my strength, Jen. So, gee, perhaps I need to see a dietitian to ask that question. Certainly, I would say yes. There's quite a lot of emerging research around meal timing and not eating meals too late in the evening, and the challenges, of course, of balancing meal timing, particularly for shift workers, and how that really throws out circadian rhythms. That's a really emerging area of nutrition research. I've also talked about not having foods too high in caffeine too late. Things like chamomile tea may help one sleep, and also, of course, the trusty trick that many of you will have had as young children, perhaps, which is to have a warm milky drink before bed. So I think that really helps to settle you and prepare you to spend some good quality time with your pillow.
Well, look, we'll leave it there. There were a couple of questions, as I said, we won't address because I think they are a bit more detailed and personal in nature. So best that those people see if they can speak to a local dietitian to seek the advice they might be needing. So look, Judi, fabulous. Thanks so much. Really very intriguing presentation this evening. And obviously by the number of questions and the attendance, this is a topic that has been of great interest to many people. So really thank you on behalf of Musculoskeletal Australia for your time and energy in preparing the presentation and putting it out there for us tonight. So thanks very much, Judi, and thanks everyone who has joined the webinar this evening. Can I remind you that our next webinar will be on the 23rd of June, and will be on the topic of osteoarthritis and exercise. So I think that's, again, another topic of great interest to many people. So hopefully, if you're not already registered for that one, please register on our website. And on that note, I will wish everyone a very good night, and same to you, Judi. So thanks again, and hopefully we'll see you all next time. Good night.